Everyone can see those? Yes, okay, great. So again, yes, welcome. My name is Gretchen Reynolds. I'm one of the neuropsychologists here. And today we're going to talk, like Nancy mentioned, a little bit about Alzheimer's or aging, some of the differences between the two. I'm also going to talk a little bit about some of the research I've been working on, which focuses on kind of the preclinical or early stages of Alzheimer's disease. So we'll talk a little bit about that at the end if there's time. But first, I just wanted to introduce a little bit about me as a neuropsychologist, what neuropsychology is, if that's helpful. Some of you might have met with a neuropsychologist. Specifically, it's a specialty within clinical psychology that focuses on brain behavior relations. So I'm a clinical psychologist by training. I don't prescribe medication, but as a neuropsychologist, I conduct evaluations to measure memory and thinking. It's mostly pen and paper testing. They tend to be pretty lengthy. Sometimes there's some computerized testing as well. But the idea really is to measure these cognitive abilities, and that can be helpful in figuring out kind of diagnosis, what might be causing some of these changes. It can be helpful in figuring out the best treatment plan. And as we'll talk about today, it can be really helpful to establish an individual baseline for individuals to kind of better track your individual, course over time. So that's one aspect of neuropsychology. And then I would just say a little bit personally about me. I'm also interested in kind of the intervention side. So teaching individuals behavioral strategies to promote memory and attention and kind of improve those skills day to day. So as part of my clinical work as well, I do run some groups that are focused on that too. And again, at the end today, we'll talk a little bit about all the research opportunities that might be available, and also from the clinical side of things, both evaluation and or groups, if that's of interest to anyone. So with that, some things we're going to talk about today, and it's just the difference, between normal age-related changes, those that occur as we get older, versus maybe those that are more common in something like Alzheimer's disease. So I think one thing that's important to keep in mind is really what is the aging process, what kind of happens, changes, good, bad, neutral, anywhere in between, and kind of how to think about that. So I'm going to start by just introducing a little bit about some of the typical age-related complaints we hear, or in the clinic, or just talking with our family members, things like that. There's some common examples up here which may resonate with some people, and I would say two of the kind of common themes would be slower retrieval of information, and then some kind of attention-related memory issues. So some things up here kind of fall into those categories. So the first couple of points here, who's that movie star, or what's that word, this kind of tip of the tongue phenomenon that we hear about a lot, like, oh, I can see the face, I just can't quite come up with the name, or maybe there's one specific word you're looking for that just for some reason isn't coming to you. That's really common. And sometimes the word comes to you maybe a minute later, maybe it comes to you a day later, or when you're lying in bed, like, oh yeah, of course it was that person. So I would say, and again, it's for, maybe kind of obscure names, a movie you watched a while ago, not for, names of people you know well or anything like that. But it's really common just to have that retrieval piece take a little bit longer. So that's one thing to keep in mind. And then some of the other, examples that come up, where are my keys? Where did I park the car? Those examples, I think, kind of draw upon and highlight the importance of attention and how that can impact memory, right? So attention is a huge piece of memory. When we test attention in the clinic, or memory in the clinic, excuse me, we think of the 3 stages of memory. You have to learn new information, store it, file it away, so that you can retrieve it later, right? And so that's how we test memory in the clinic, and memory can kind of break down at any one of those stages. Attention in particular is hugely important for that front end side of memory, right? That learning some new information. So the examples like, where are my keys? Where did I park the car? If I didn't pay attention to where I put my keys down when I came home, right? Maybe I was rushing and, rushing to get somewhere. I threw them somewhere. I wasn't paying attention to it. I might, forget where I put them later, but maybe I never paid attention to where I put them down, right? Particularly if I got distracted and I didn't maybe put them in my normal location. Same thing with parking the car. again, hypothetically, maybe I was late to an appointment, I was parking in a new garage that maybe I hadn't been to before, and perhaps I didn't take note of exactly which level of the garage I was on. That could potentially make it much harder to find my car later. But the question is, did I forget where I parked it, or did I never really learn it to begin with? So those are just some things to keep in mind that can be really common, when we're trying to manage multiple pieces of information. And then the other thing, we've kind of probably all had this experience of going into the kitchen or going down to the basement, and then all of a sudden, like, what did I come in here for? What was I going to do? And that too, maybe if I wasn't paying full attention to why I came in here, or someone distracted me, started talking to me, and my phone rang, maybe again, I just wasn't totally focused on what I set out to do. So all of that can be pretty common, I would say, as we get older. And I would just say here too, when we think about age-related changes, memory, of course, is a big one that we see, but we can test various cognitive domains as well. So, as a neuropsychologist, when we're testing in the clinic, we of course test memory, but also, like I mentioned, things like attention, language, processing speed, visuospatial abilities, executive function. If people are familiar with that term, one way to remember it is like the executive of a company or the executive of a household, right? That person has to potentially delegate, plan, organize, multitask, make decisions. So that's kind of another broad term we think about. And so when we're thinking about just aging as we get older, some aspects tend to increase with age over time. So things like our vocabulary, word knowledge, these are kind of cumulatively building as we get older, right? I love the idea of thinking about kind of the sense of wisdom that continues to grow as we get older, just with life experience. That's something that is always building. So those are things that increase with age. And then on the other side here, things that do slowly kind of decline over time as part of just getting older: processing speed, verbal memory, and then again, a lot of these what we call executive functions. So being kind of able to multitask quickly, be flexible in our thinking, quickly do mental math. Some of those might kind of diminish over time. And I think it's important to note here too, is that these kind of age-related changes, they start early in adulthood. So in our 30s, kind of speed of processing starts to kind of slowly decline, and that's kind of cumulative just as part of normal aging across the lifespan. So that's kind of the cognitive side of things, but then what's actually happening in the brain, just kind of generally speaking, as we get older, the brain does shrink in size, so kind of decreases in brain size, and diminish what we call white matter integrity. So the brain is made up of gray matter and white matter, and white matter tends to be the connections between different brain regions. And so that can kind of diminish over time as well. And if you look at this picture here, here's kind of maybe a non-aged brain here on the left-hand side. And if you compare that to just a brain that's a bit older, if you see these kind of like black, it's just space. So there's more space. The brain has kind of reduced in size in certain areas. And when we're thinking about specific areas, you might have heard of the hippocampus. It's one of kind of the main memory centers of the brain. And it's shown in these kind of blue boxes here. And just again, as part of normal aging, there is some cell loss in that region. So you can see here this younger brain, person in their 20s, there's really no space there in this hippocampal region. Whereas again, someone much older who's made it to 87, there is just some more space. And so that just suggests there has been some shrinkage, but that doesn't by itself indicate significant memory loss. So now I'll just shift a little bit. So we talked about some kind of the normal changes that occur as we get older, but what might raise concern for something that's more serious? And one thing before I start, it's really important to keep in mind, one of the biggest things to be mindful of is what's a change from someone's baseline, right? Because that's what's of most concern, is when there are changes that feel very different from how someone used to function. So one thing that might be more concerning is someone repeatedly asking the same question, with just kind of no recollection of having asked it just a little bit earlier. Getting lost, particularly in places you know well, could be concerning, especially that raises safety concerns for driving that we're always really mindful and worried about if that's coming up. Not being able to follow directions. And again, with these two, I would just say too, some people maybe have never had a great sense of direction, right? And maybe that's the same as it was 20, 30 years ago. That's very different from someone who has always, navigated quite well and now is getting lost again, particularly in familiar places. That would raise some more concern. And then I would just say too, like a general sense of kind of confusion. Again, different from someone's baseline, mixing up things about time, certain people, places, and kind of showing more confusion in that regard could be more concerning. And then certainly kind of at later stages too, anything that raises concern for poor self-care. So changes in eating habits, hygiene, any unsafe behaviors at home, things like leaving the stove on are certainly more concerning. And then sort of kind of summarize those, the two examples, right? So on the left-hand side, things that are more concerning, again, they're just more serious that might raise concern for some sort of memory disorder like Alzheimer's, versus things on the right-hand side that are maybe part of normal aging, right? So again, the difference here, poor judgment and decision-making, again, particularly if it's significantly different from someone's baseline, versus someone making a bad decision once in a while, right, is a little bit more common for anyone at any age. Managing finances is something we often ask about as well. So if someone is no longer able to manage a budget, is making errors that they haven't, made in the past, that certainly raises concern. Versus maybe I miss a payment once in a while because I had too much going on, or I dropped the ball for whatever reason, right? When I talk about that idea of like confusion of time, people, places, people are frequently losing track of the date, particularly, the season, the month, not, is it the 11th or the 12th or something like that? But more, significant confusion about what season or month it is, that raises concern, versus what's relatively normal is maybe forgetting what day it is and then remembering later. And I would just argue here too, particularly during the pandemic, if the days kind of blend together, and or during retirement, if I'm like, oh, is it Monday or Tuesday, but I don't have quite as much on my schedule, that's less concerning than if I'm, confused about what season, month it is repeatedly, and kind of unable to find that information later. In conversation, something that's a little bit more concerning is if someone, is having difficulty following along, kind of having a conversation versus maybe, again, that tip of the tongue, having trouble finding one particular word here and there. And then misplacing items and being kind of unable to retrace your steps to find them, having kind of no recollection of what happened is certainly more concerning than misplacing or losing things from time to time. And again, just with all of these, again, what's the change from someone's baseline level of functioning is important to keep in mind. All right, and so then next, I just want to shift a little bit and kind of the stages that we think of with Alzheimer's disease and kind of some of the research that we're working on there. So, the clinical diagnoses can follow kind of these three stages. So subjective cognitive decline, which is one area of research I'm interested in, mild cognitive impairment, and then dementia. So subjective cognitive decline means that the individual or a loved one or physician is noticing some sort of change in memory or thinking, but they're still performing normally on standardized tests, okay? So that's that, kind of maybe early preclinical level. When it gets to the level of mild cognitive impairment, that's when we are picking up impairments on standardized testing that are above and beyond what we would expect for age, but the person at this level is still functioning okay at home, so they're still able to manage what they need to do in terms of medications, finances, those sorts of things. Certainly they might have to be using reminders or things like that a little bit more, but they're still able to function independently. When it gets to the level of then dementia, there's more marked impairment on standardized testing. And at this level, the individual is having trouble doing things in their day-to-day. So it could be trouble driving, again, managing finances, medications, appointments, cooking, and so they're needing some assistance there. These are the clinical diagnoses, and then you think about, okay, what's causing that, right? And so that's where Alzheimer's disease is a type of dementia, and it's the most common type in aging that could be causing it. All right, so I hope that framework can sometimes be confusing, so happy to answer questions about it at the end as well, but that's kind of how we think about it research-wise and in the clinic. And I would just say too, clinically, neuropsychological evaluations are often done for people in kind of the subjective or mild levels of impairment because it can allow us to have a baseline and then track potential changes more closely over time. And then this is just, if anybody is more of a graphic or visual person, this also just kind of shows, again, the distinction between normal aging and changes in cognitive functioning versus something like Alzheimer's disease, which is, again, is not normal aging. So this red line, you can see my cursor up here, shows what's normal for aging. So as we get older, going this way, there's a gradual cumulative decline in cognitive function, but it's nothing like a sharp drop off, right? If you look at this blue dotted line in contrast, you can see in these early, again, these preclinical stages. So this would be where people aren't showing impairment on testing. Again, maybe that subjective level of decline that I just mentioned. And then over time, it does tend to it drops off more quickly, right? So then mild cognitive impairment, you're seeing more decline in functioning on testing, and then it continues to decline at the level of dementia. And then the last little bit here before I turn it over to Phil, I just want to talk a little bit about, again, these stages here. So these preclinical stages, which is just an area of interest of mine from a research and clinical perspective. So subjective cognitive decline is really common as we get older. And so this is, again, just noticing changes, right? Subjective changes among people who then perform normally on standardized testing. So just in the general community, the estimates are pretty variable, but anywhere from 25 to up to 50% of older community samples report some memory complaints. And even if you look at people ages 45 and above, 11% of people report some type of memory complaint, and certainly this increases with age. So it's really common, is one thing to know, just kind of this memory complaint. But then this statistic here in the bottom right, I just want to highlight, is that then less than half the people who notice some of these memory complaints have discussed those symptoms with their healthcare provider. And so that's something I'll just highlight a couple times today, but just the importance of, if you notice memory concerns, you have complaints, or a family member is noticing something, I would really encourage you to discuss that with your primary care, just to see what they think of it, what's going on. Do they think any other workup would be helpful? And then just the last little bit about kind of the research side of things. So how do we assess for, again, this idea of subjective cognitive decline? Because people, again, on the testing, the actual standardized testing, they're going to perform broadly within the normal range. So what we do then is we're asking about, have you noticed a change in the past year or so that's been persistent? So it's not something that comes up, 1 month, but then it kind of, goes away. And we have, specific questionnaires that are both for the individual themselves to report on what they've noticed, and also for their study partner or family member, loved one in the clinic setting. And these are questions, again, asking about some of the things I've mentioned. So misplacing items, trouble managing appointments or driving, that sort of thing. And what's really important, and as we learn more about this, is just it's so valuable to have both the individual perspective as well as the perspective of a loved one or a study partner. And so I'll talk a little bit more about that research in a few slides, but I would just kind of highlight that piece. It's hugely important. And in the clinic, when people are coming in for a baseline evaluation, we often ask if they have someone that would want to join them for the, kind of initial interview, a family member, loved one, friend, just to kind of get both of those perspectives. Now, another thing I do want to note, SCD, subjective cognitive decline, can be associated with, again, future cognitive decline and preclinical Alzheimer's for people that have those brain changes going on. Now, at the same time, it can also be due to a number of other reasons. So it's commonly associated with things like mood changes, depression, anxiety, physical health concerns that might be going on, and a variety of demographic factors too. So again, it increases with age, lower levels of education we're finding might be kind of contributing, lifestyle factors as well. And so there are a lot of different things that can be associated with subjective cognitive decline. So I just want to make sure that point is clear too. Not everybody who notices these changes has underlying Alzheimer's disease, but among the people that do, it might be kind of one of the earliest changes that the individual is noticing. And then more specifically, again, so you can see here, there's so many different factors that might contribute to subjective cognitive concerns. But there are some that particularly might raise more concern that there could be something like early preclinical Alzheimer's disease. And the things that the research has shown that are related to that are particularly if people are noticing changes in memory specifically, rather than things like attention, language, processing speed, other areas of cognition. If the onset of the concerns is relatively recent, so within the last 5 years, versus something that, that's maybe I've been noticing memory changes for 20 years, that's different. If the age of onset of noticing some of these subjective concerns is when you're 60 or older, again, just because age is one of the biggest risk factors for something like Alzheimer's disease. And then if the person is worried about the concerns, right? So sometimes people, they might have memory concerns or complaints, but they're not particularly worried about it, right? They've noticed some changes, but it's not bothersome to them. That's different from people who are noticing a memory change or cognitive change and are really concerned and worried about it. That might, again, hint that there's something more going on. And then this point too, certainly, we talk about what's a change from someone's individual baseline level of functioning, but also I would say what's a change or what's different from people, your peer group, right? So how do I feel like my memory stacks up to my peers? Sometimes I ask people that, and they feel like, oh yeah, most of the people my age group, they have the very similar, experience. Versus other people like, no, I feel like my memory is significantly worse than my peers. So that's another way to kind of think about it. All right, and so then just to summarize a little bit, again, subjective cognitive decline, that's again, these kind of like early preclinical stages. Can be for some people, it's a transitional stage that for some people who do have underlying Alzheimer's disease, it might represent some of the earliest symptoms that people are noticing when we're not picking it up on standardized testing yet. At the same time, that is certainly not true for everybody. It can be, related to a number of other factors, things like mood, lifestyle, it might differ by ethno-racial group as well. So it's certainly a really heterogeneous condition. And then, as I mentioned, one of the, again, most important things we're learning from some of the research and clinically is just it's so valuable to gather information about these changes from both the individual themselves as well as a family member, friend, study partner, loved one, and to have that kind of dual perspective. Early on, it might be the case that the individual notices some very subtle changes that aren't really apparent to others yet. But then over time, the study partner might be picking up on more changes, particularly for those people where the individual experiences cognitive decline. And so at that point, the study partner maybe notices some more information that's hugely valuable as time goes on. All right, and so then just the last few minutes before we shift gears a little bit, and again, I can answer more questions at the end as well, but there are several study opportunities that I'm sure you'll get more information about from the team here for anyone who is worried about their memory. Memory testing is often done as part of the study, and there's a wide number of studies that require, different ages, different experiences in terms of doing it online or in clinic. So this is the link, to some of these studies if you just want to learn more and see if any are a good fit that you would be interested in. And then just clinically, I would just say too, again, If you notice concerns or it's something you're worried about with a change in your memory that you or a loved one has noticed, I would just encourage you to talk with your primary care about it. They can help you figure out what would be helpful next steps. And we can certainly give some more information about where we do neuropsych evaluations in the clinic here in Boston, as well as if you're ever interested in doing some of kind of the memory skills groups. Again, that's from a clinic perspective. We're happy to provide more information on that as well. All right, and so with that, yeah, I think I will turn it over to Phil, our research ambassador now, but thank you all so much for your attention today, for coming, and thank you to everyone who makes this work possible, the participants, study partners, and the big research team. So thank you so much, and I'll turn it over to our hosting research ambassador, Phil, at this point.
All right, thank you very much, Dr. Reynolds. Very, very informative, very much appreciate that. Good afternoon, everyone, and welcome. Thank you all for tuning in and expressing your interest. You just heard the clinical portion of the presentation from Dr. Reynolds. My name again is Phil Cunningham. I'm here in two roles today. First as a research ambassador, and I'll tell you a little bit about what that means. And second, as a clinical trials participant, I will also say what that has been like over time and what benefits, more importantly, what benefits have accrued to me as a result of being a clinical trial volunteer. In 2015, I became a clinical trial participant, and that trial is still ongoing, and it really has become part of my identity. By virtue of that participation, I was invited to become a MADRC research ambassador, Mass Alzheimer's Disease Research Center research ambassador. It's a fancy title, but there's no six-figure salary, no private car or chauffeur, I can assure you. But what exactly is a research ambassador, you might ask? So some of the things we do are in public and behind the scenes. We attend community events under the broad umbrella of outreach, meaning take the message out to the public. We speak at research presentations. I do about my experience, like I'm doing now. We talk informally to individuals interested in studies, and in the background, we review materials designed for research outreach, such as handouts, flyers, presentations, offer suggestions for improvement, and we provide feedback for the programs for supporting research participants. So that's what a research ambassador does in a very broad overview. A few more words about my background for your context. I'm not a clinician. You just heard from one, but I'm not. I'm just a regular guy. I'm a husband, father of twins, and a grandfather. In the 1970s, during and following the Vietnam War, I was an Air Force officer for 9.5 years. I was a pilot for the first 6 years, and then an engineer. After leaving the Air Force, I had a 35-year engineering career where I led intelligence analysis and system acquisition efforts, primarily in support of the United States government. I retired in 2014 as a department head from an engineering firm in Bedford, Massachusetts. Okay, why did I choose to participate in an Alzheimer's disease clinical trial? Both of my parents were of the greatest generation. They led fairly active and healthy lives, which included working and volunteering. My father's death in his later 70s was not related to Alzheimer's disease. My mother was very independent. She lived until the age of 98, but in approximately 2005, when she was around 90, I saw significant changes in her cognitive function and activities of daily living. I was resonating with the previous briefing, thinking about her. As her healthcare proxy, I took her to a number of doctors, one of which was a neurologist. She didn't really go willingly, but she went. Using a short evaluation tool called the MMSE, or Mini Mental Status Exam, the neurologist diagnosed her with dementia, probably from Alzheimer's disease. Now, truthfully, I was never sure about this diagnosis because she did not have an extensive workup, such as the one that Dr. Reynolds would do, or she just described. But my mother took an FDA-approved prescription drug for about 8 years until she died of other causes unrelated to dementia. But the drug seemed to stabilize her cognitive state. I can't say that for sure. So I had some satisfaction in intervening earlier in her end of life years. Like some of you, I have friends and former coworkers who have been affected by Alzheimer's disease, dementia. I've seen how their lives and families' lives have changed significantly. So my motivations for joining a clinical trial were really twofold. Perhaps selfishly, if I was destined to develop dementia, I wanted to do all I could to prevent or forestall that outcome. Secondly, both of my parents had donated their bodies to medical research after their deaths. I thought that if I could help advance the collective knowledge on dementia and Alzheimer's research while alive, that would be a good thing. Excuse me. So it's not possible in a short amount of time to articulate all of the benefits I have derived from being in a clinical trial. I'm going to mention a few. I'm taking positive steps that may contribute to the research of the body of knowledge. I joined the study as an individual, not with a group of friends or neighbors, but I found I have joined a community of people, much like me, who are willing to share their experiences. I belong to an informal email group that I've met along the way, including folks at Rush University in Chicago, Brown University in Providence, a person in Florida, and a number of people in the Boston area, some of whom I know are actually online right now. The staff members at the Brigham and Women Center for Alzheimer's Research and Treatment are extremely professional, yet personable. They're wonderfully dedicated and highly motivated people. About once a month, I have received an infusion starting in 2015, as I said. In the early stages of the clinical trial, it was either an experimental drug or a placebo. I have been in the trial long enough now to be in the open label phase, which means I am receiving the drug. I know I'm receiving the drug, still an experimental drug. This drug may or may not have cognitive benefit. We just do not know yet as the trial winds down and data is analyzed. It's still ongoing, but it's going to come to an end pretty soon. For me, and most of my participants, I believe, a typical visit lasts about an hour and a half, except on days when there is testing, then perhaps adding 20 minutes or so. In summary, I just share you with some last thoughts here. I wish I could participate in a number of clinical trials concurrently. Call me crazy, but that generally is not permitted because it might skew the data and the study outcomes. One might influence another. You may think it is a time-consuming burden to participate, but really, I've realized that I have received so much more back than what I have given in being a clinical trials participant. And I've also learned along the way, as most of you know, there's a significant need for clinical trial participants worldwide in many areas, especially participants in minority groups. So that's really what I want to say as far as my little role in being a research ambassador and a clinical trials participant. I hope you enjoyed the doctor's presentation and my few words. I hope you've been inspired and you would seek additional information. I encourage you, if you're questioning your aging process or your cognitive process, do seek medical help. You may pleasantly be surprised and you may get the support that you need. Don't hesitate. So that's all I wanted to add to this presentation today. And I'll thank you all, and I'll return the mic, if you will, back to Christine Brown.